Everyone, today we are going to do a very important 10 marker, that is going to be the herpes simplex virus, which has been asked multiple times as a 10 marker. So let's start with herpes simplex. Firstly, herpes simplex is also called acute herpetic gingivostomatitis, okay, and herpes labialis, fever, blisters, cold and sores. Okay, so these are the major common symptoms, that is your herpes labialis, fever, blisters, cold sores. Now coming to the classification, human herpes is divided in HSV1, HSV2 and EVB and HSV6, 7 and 8. So mainly you have to remember that there is herpes simplex virus 1, 2, and you have your Epstein-Barr virus, and then you have your HHV6, 7 and 8. Okay, so this is this classification. I'll just show you, give me a second. Yeah, so this is the herpes classification that you mainly need to know. So herpes virus, in that you have herpes simplex virus 1, herpes simplex virus 2, varicella zoster, then cytomegalovirus, Epstein-Barr virus, and then human herpes virus 6, 7, 8. Okay, then lastly you have similar herpes virus. So that's the broad classification of herpes virus. That is what is written here: herpes simplex virus 1, herpes simplex virus 2, varicella zoster, Epstein-Barr virus, cytomegalovirus, herpes virus 6, 7 and 8. Okay, now coming to herpes simplex. What is herpes simplex? It is an acute infectious disease. Okay, so it is acute and it is an infectious disease. Now it belongs to the family of herpes viridae. Okay, so the group of viruses herpes viridae, it belongs to that group. Okay, now the structure of the herpes simplex, it is composed of a double-stranded DNA, double-stranded DNA and protein capsid with tegment and lipid envelope. So herpes has a double-stranded DNA with a protein capsid, tegment and lipid envelope. So all this you have to know. Okay, so this is basically the structure of the herpes, that it is double helix and double-stranded, yeah, and it has protein capsid, tegment and lipid envelope which contains your glycoproteins. Okay, then you have types. I have discussed type 1 and 2 in brief. Okay, so type 1 is which spreads predominantly through saliva. Okay, so and it is adapted best to oral or facial areas. So this is our interest. Okay, and pharyngeal, intraoral sites, lips, eyes, skin, abdomen, waist involved most frequently, and usual ganglia involved is the trigeminal ganglia. Coming to HSV2, HSV2 is transmitted through sexual contact, adapted best in genital zones. Now this is your oral zone, lips, saliva and facial structures like eyes and the skin above the waist. And coming to the HSV2, which is spread through sexual contact and genital zones, it is best observed in and it is seen in the skin below the waist. Okay, and then coming to the pathogenesis, it primarily infects so how it primarily infects is it is in direct contact with the affected area or through secretion. So direct contact is your sexual contact. Okay, and your so one way that it can be transmitted is your sexual contact. Then the second way is with affected area, so contact with the affected area or through secretions. As we discussed earlier, saliva is an example of that secretion. Now virus, through its specific receptors, is attached to the cells at inoculation site. So virus, through its specific receptors, okay, it attaches to the cell at the cell inoculation site, okay, then that reciprocates too many divisions and discharges to neighboring cells, okay. So it basically replicates. So once the virus enters the body through a direct contact or salivary secretion, it then transmits in the receptors. So virus has the specific receptors and it attaches to the host cell through these specific receptors, okay. After that it replicates and too many vivians and discharges. So basically it replicates into daughter, usually this is daughter virus. So basically it replicates into many viruses and discharges to the neighboring cells. Subsequently it affects the adjacent cells and spreads to distant sensory organs, nerve endings, and autonomic axons, further to adjacent related ganglia, and then remains latent. So what is latent? We discussed earlier that it occurs in periods and it gets activated in periods, okay. So it is period of activation. Coming to the secondary infection, so this was the primary infection, that there is a direct contact, that is your sexual contact or contact through the secretions, that is your saliva or different secretions. Then this virus, through its receptors, attaches to the host cell and then starts replicating in the host cell, and uh, it divides into too many vivians, that is the daughter viruses, and discharges to the neighboring cells. Basically it spreads to the neighboring cells, then it affects the adjacent cells and then the nerve endings, ganglia, and then goes into dormancy or latent stage. Then secondary infection. So secondary infection is a susceptible host. Susceptible host undergoes primary infection. Once primary infection is there, it has clinical diseases and subclinical infections. Then it goes through latency, then latency gets excited, and then secondary infection is occurring and recurrent manifestations can be seen. So that is your secondary infection. So primarily when the cell lyses, you see the primary infection, where so basically when the virus spreads, you see this primary infection, and once the virus goes into the latency stage and again gets excited, is your secondary infection. So in your primary infection you see clinical diseases, that is your gingivostomatitis, primary vulvovaginitis, inoculation herpes simplex, varicelles from eruptions, meningoencephalitis, disseminate visceral herpes simplex, okay. So these are the clinical diseases. You do not need to remember all these, but you can mainly remember is gingivostomatitis and vulvovaginitis, and if possible you can remember meningoencephalitis as well. So these are a few clinical diseases that occur in the primary stage in 1% of the primary infection, and in 99% of the primary infection there is no visible disease. This is rare, okay. The 1% that we talked about, gingivostomatitis, vulvovaginitis, meningoencephalitis, is only in 1% of the clinical diseases that affect the primary infection. But the 99% cases, the subclinical infection, there is no visible disease, and circulating antibodies uh, in the blood. So basically what happens is, in subclinical infection there is no visible disease because there are circulating antibodies in the blood, okay. These antibodies cause the period of latency, okay. and then once there is a period of latency, basically that it becomes dormant, then when it re-excites again, that is, it could be due to various triggering factors that it is re-exciting. That could be sunshine, fever, GI upsets, mechanical trauma, allergy, anxiety. So there could be various triggering factors that could cause the excitants to get excited after the latency period. So once they get excited, the secondary infection is seen where there are recurrent manifestations such as fever, blisters, genital herpes, and dendritic corneal ulcers. Okay, then coming to the clinical manifestations or clinical features, first is the primary herpetic gingivostomatitis. This is, we're talking about the 1% clinical diseases that we see. In that, we first have the primary herpetic gingivostomatitis, right? So we're going to deal in detail with primary herpetic gingivostomatitis. Okay, so we discussed that the pathogenesis of HSV. Now we are moving forward with the primary herpetic gingivostomatitis. So what is primary herpetic gingivostomatitis? It is a clinical disease which is occurring in 1% of primary infections, which has the clinical diagnosis as well. So it usually occurs in children and young adults. Okay, children aging from 6 months to 5 years. Okay, and young adults. Development before 6 months is rare because of protection by maternal antibodies. Okay, then older adults, it occasionally occurs. Coming to the features, the onset is abrupt. Anterior cervical lymphadenopathy is seen. So here we're going to mainly discuss this, what and all are the symptoms. So first is the anterior cervical lymphadenopathy is seen. Okay, so cervical lymphadenopathy is seen, chills, fever, nausea, anorexia. So if you don't know what anorexia is, loss of appetite is anorexia. Okay, so it occurs in children mainly, that is 6 months to 5 years, and then it is very occasional in adults. And if it is occurring in children, it is not occurring before 6 months, because it might occur, it is rare before 6 months because it is protected by the maternal antibodies. Now the basic symptoms are cervical lymphadenopathy, chills, fever, and nausea, anorexia, irritability, sore mouth lesion, and pain on swallowing. Now coming to the appearance, initially it affects the mucosa. Okay, so appearance of the mucosa we're talking about. So initially mucosa is affected and it develops numerous pinhead vesicles. Okay, so it initially develops pinhead vesicles. These pinhead vesicles rapidly collapse to form numerous small rep lesions. Okay, these lesions enlarge and develop into central areas of ulceration covered by a yellow fibrin. Okay, so first is your pinhead vesicles. These vesicles then grow or collapse to form numerous, basically like this, like this, like this. These collapse to form numerous small rep lesions, and these lesions enlarge. Okay, so basically they enlarge, and this develops into an area of central ulceration covered by a yellow layer of fibrin. Now the adjacent ulceration may coalesce to form large, shallow, irregular ulceration. So adjacent ulceration, so ulcerations which are next to each other may coalesce to form a larger ulceration. Okay, now both are movable, attached to oral mucosa, Okay, so both the ulcerations are movable and they're attached to the oral mucosa. Then the number of lesions is variable, so there is no specific number of lesions. Then they heal spontaneously within 7 to 14 days. Okay, so these ulcers which occur, they heal within 7 to 14 days. Now coming to the gingival enlargement. Gingival enlargement is the gingiva is enlarged, it is painful, extremely erythematous, okay, and punched out erosions alongside the mid facial free gingival margin. Okay, so basically there are punched out lesions which are seen in the gingiva. Okay, then there is involvement of labial mucosa which extends past the wet line, that is your vermilion border of lip. So the where the labial mucosa is involved, that area is further extending onto the vermilion border of the lips, past the vermilion border of the lips. Then the satellite vesicles of the perioral skin is common. Then there is inoculations of fingers, surf inoculation of fingers, eyes and genital areas. So this is your clinical features. Mainly, firstly, it is seen in children, young adults, not seen in older adults, or occasionally seen in older adults, and it is often abrupt on onset and severe lymphadenopathy seen, chills, fever, nausea, anorexia, irritability, sore mouth and painful swallowing is seen. Then coming to the appearance, the mucosa appears so the mucosa is mainly affected. How it appears is, it appears like a pinhead vesicle. These pinhead vesicles together coalesce and form red lesions. These red lesions then enlarge, and then they uh, when they enlarge, they coalesce again or collapse again and form enlarged central ulcerations. These ulcerations, which are adjacent to each other, also may coalesce to form again more larger ulcerations, which are usually coated with yellow fibrin layer. Okay, then both movable and attached oral mucosa is affected. Number of lesions is variable. These lesions heal spontaneously within 7 to 14 days. Coming to the gingiva, gingiva is painful, enlarged, and there are punched out erosions on the gingiva, and it is extremely erythematous. Now the labial mucosa. So gingiva, you need to remember 4 points: that it is enlarged, extremely painful, red, that is your erythematous, and it has punched out erosions. Then coming to your labial mucosa extends past the wet line, that is the vermilion border of lips. So labial mucosa extends the vermilion border of the lips and serve in inoculations of fingers, eyes and genital areas is seen. Now mild cases resolve within 5 to 7 days. Severe cases take up to 2 weeks. Now rare complication is, it could cause meningitis, encephalitis, esophagitis. So different infections or inflammation can be caused, because eventually it is a viral infection. Now coming to the first complication or infection, primary infection. So we are basically talking about these clinical diseases, right? So there is also something called as pharyngotonsillitis. In pharyngotonsillitis, the primary infection occurring in adults. So we discussed about the infection occurring in children, that was your herpetic gingivostomatitis. Now we are discussing something known as pharyngotonsillitis. This is something which is occurring in adults. Okay, so what is pharyngotonsillitis? It is a primary infection occurring in adults, which sometimes manifests as a pharyngotonsillitis. So the initial symptom is sore throat. So the initial first symptom is sore throat, followed by fever, malaise, vesicles. Okay, so basically sore throat, then there is fever, then there is malaise, that is pain or muscle pain. Okay, so sore throat, fever, malaise, and vesicle formation, which develops on the tonsils and the posterior part of the pharynx. Okay, these vesicles rapidly rupture to form numerous shallow ulcerations, and then these shallow ulcerations then coalesce with one another. Diffuse gray yellow exudate form over these ulcers. So how is the lesion of the tonsils and pharynx? Firstly, the infection occurs in adults. Second is there are few initial symptoms, that is sore throat, fever, pain, and then there is development of vesicles. Now these vesicles are rapidly rupturing to form shallow ulcerations. Then those shallow ulcerations coalesce with one another and release a gray to yellow exudate. Okay. Now coming to the recurrent or secondary herpetic labialis or stomatitis. So what is recurrent or secondary herpetic labialis or stomatitis? It is the recurrence of HSV, commonly leads to herpes labialis, cold sores, what we commonly call. We are going to see what these cold sores are. So etiology is the pathogenesis and risk pathogenesis and risk factors. It is here. I had already told you that these are your risk factors or your triggering factors for the secondary infection, that is sunshine, fever, your mechanical trauma, allergies, anxiety, etc. is your etiology or triggering risk factors. And coming to the age, it occurs in adults. Occurrence is widely varying in intervals. Majority to recurrence annually. Okay, so small percentage monthly or even more frequently. So it occurs widely, then it takes an interval, and then it reoccurs on an annual basis, or sometimes it could also reoccur on monthly basis or more frequently as well. Now coming to the site, the lesion may develop at the site of primary inoculation. Okay, so lesion may develop at the site of primary inoculation, where the lesion is primarily inoculated. There a lesion could develop, or the adjacent area which is supplied by the ganglion. Okay, so basically which part of the ganglion? So the adjacent area. So basically, if let's say if it is occurring on the lips, the virus has entered through the lips, then the initial lesion will be on the lips. Okay, then it will spread to the ganglion which is present nearby. Now coming to the oral mucosa, that is tightly bound to the periosteum. So basically its route of spread is the oral mucosa, which is tightly bound to the periosteum. Attached gingiva, tightly bound and mobile mucosa, lips, as I gave you an example of, and vermilion border. Okay, now what are the prodromal signs? Basically the initial signs of the secondary infection. First is pain, burning, itching, tingling, localized warmth and erythema of the involved epithelium. So there is pain, there is burning, there is itching, there is tingling, and there is localized warmth in that particular area where there is erythema. Okay, so appearance, small erythematous papules appear, then these papules fill fluid filled vesicles. So basically same, that these, there is a formation of papules, those papules collapse, then they form ulcers, those ulcers coalesce and form a large ulcer. that is common for all the papules or lesions of the herpes. So that is, there is small erythematous papules, they clusters of fluid filled vesicles coalesce, rupture, then form ulcerations. Okay, then that forms your erythematous hat. Now coming to the lips, these ruptured vesicles covered by a brownish crust. So those ruptured vesicles are covered by a brownish crust that is healed within 7 to 10 days. Now pain could be variable. Now what is reptic whitlow? So reptic whitlow is self-inoculation in thumbs and fingers. So the bacteria is inoculated in the fingers and thumbs. Causes is your primary infection through direct exogenous or autogenous inoculation through trauma. So basically, if there is a cut in the skin or there is a break in continuity of the epithelium or due to some trauma, then the virus might enter through those thumb, fingers, and that is your self inoculation. Then that causes presence of vesicles, then those vesicles coalesce, they form a large honeycomb like bulle in 1 week. Okay, then this infection is usually self-limited, so basically that infection stops there only and it resolves in 2 to 4 weeks. Okay, then coming to herpes genitalis. So we spoke about uh, let's see, okay, we spoke about gingivostomatitis, that is primarily occurring in children. Then we spoke about pharyngotonsillitis, that is occurring in adults. Then we spoke about herpes labialis or secondary stomatitis. Then we spoke about reptic whitlow, that is your uh, self-inoculating virus in the thumb. This is this infection which is usually self-limited. Now we have to discuss herpes in the genitalis and meningoencephalitis, conjunctivitis. Then you have your eczema, disseminate herpes. Then we're going to see the histopath of the herpes, then diagnosis and treatment. Okay, so let us complete. Coming to the herpes genitalis, so this is the herpes which affects the genitals. It is caused by HSV2. Okay, it is common in diseases of uterine, cervix, vagina, ulva and penis. Okay, now what is herpes genitalis? It is caused by HSV2. It is having a clinical symptom of fever, muscle pain, rash and headache. Appearance is same. This is very common, this that they appear in papule, blister, ulcer. Remember this sequence for all the manifestations. Now then there is infection with HSV2. Then there is transmission rate and risk for acquiring HIV. Okay, so basically the body becomes prone for HIV infection because of the infection of HSV2 in the genitalis. Now coming to something called as herpes meningoencephalitis. What is this now? It is a serious form of HSV infection. Okay, so this is a serious form of HSV infection, then of which pathogenesis is HSV can reach the CNS. Okay, this is very obviously if something that is affecting the brain or the CNS. Meningoencephalitis is the infection of the meninges. Okay, so HSV can reach the CNS through the olfactory and cause the forebrain herpes simplex encephalitis. Okay, then so basically it affects the forebrain, and forebrain is basically your a part of your brain. Okay, and it affects that, and it can reach the CNS through the trigeminal ganglia. Okay, remember this is also very important that it affects the trigeminal ganglia and causes brain stem HSE. Okay, so what is this? That is the sudden symptoms of fever, headache, altered consciousness, seizures, confusion, and brain changes. Okay, so paralysis of various muscles, convulsions, and even death may occur. Okay, so this is the most severe form. Now coming to the herpes conjunctivitis. So you got the drill here. It is basically affecting the brain, and because it is affecting the brain, it is causing severe symptoms, and in worst case it might cause death as well. Okay, now that is okay. So as we were discussing that it is a brain infection, meningoencephalitis. So after that we have something called as herpetic conjunctivitis. So what is herpetic conjunctivitis is basically it causes the swelling and congestion of the palpebra conjunctiva. So there is a swelling, congestion of the palpebra. Okay, palpebra conjunctiva of the eye, that is causing swelling, and keratosis and corneal ulcerations may also occur. So you basically have to say that ulcerations can also occur, and herpetic vesicles of eyelids typically heal rapidly. Now coming to your herpetic eczema. What is herpetic eczema? We will see. So herpetic eczema is disseminated epidermal form of herpetic infection superimposed on a preclinically existing eczema. So basically this is a superimposed kind of HSV, that is eczema. When a person is suffering from eczema, there is a superimposed HSV which leads to your herpetic eczema. Okay, eczema. Okay, so that is herpetic eczema. You do not need to know much about this, but it is, again, see this, if you have to make a good 10 marker, you have to attach this line that there is formation of vesicles, these vesicles have fluid, then these vesicles eventually collapse, they form an ulcer, those ulcers fuse with each other or coalesce with each other and form irregular ulcers. So that is happening in this as well. There is high fever in this, and this is usually very serious in nature. Now coming to the disseminate type of herpes, which is of newborns. Okay, so this is our next type, disseminate herpes simplex of newborn. So neonates acquire the infection during the passage through birth canal of mother suffering from herpetic vulvovaginitis. So this is a congenital kind of herpes, that is it is not like a inherited problem, but it is transferred from the mother to the baby through the birth canal. Okay, that is from the usually occurs in mothers suffering from herpetic vulvovaginitis. So there is transeptal infection also can occur. Infants manifest this disease by the 4th to 7th decade of life, that is 40 to 70 years. Okay, and surviving infants also show some neurological involvement. Now here we finish the clinical manifestations. There were a lot of clinical manifestations. I hope you understood clinical manifestations. If not, please comment down below on what you did not understand. I feel like even if you did not understand, if you read the notes, you might just understand. So that is your clinical features. Now lastly, there are two more parts left, that is your histopath and diagnosis treatment. Okay, so coming to the histopath, so the herpetic vesicle is an intraepithelial blister. Okay, So this is very, very important that it is an intraepithelial blister. The infected cells show nuclear clearing, nucleus enlargement, swollen eosinophilic cytoplasm, and acantholysis. If you remember, we had studied about pemphigus and Zang cells in pemphigus. Same way, where we see acantholysis, that is your break in the basement membrane. After there is a break in the basement membrane, there is a there is collection or lumps of your epithelium, that is your Zang cells. These are your free floating cells. Okay, so main histopath is your, first you see your intraepithelial blisters. These cells which are basically infected show nuclear clearing, enlargement, and eosinophilic cytoplasm. Okay, now then you see ballooning degeneration. Then acantholytic cells are termed as Zang cells, as I told you. There is nuclear fragmentation. Okay, then there is also something called as Lipscomb's bodies. Okay, Lipscomb's bodies, these are your intranuclear inclusions, which are eosinophilic, ovoid, homogeneous structures. Okay, so your uh, intranuclear inclusions are eosinophilic, ovoid, and homogeneous. Okay, intranuclear inclusions which are eosinophilic, ovoid, and homogeneous in structure. They tend to displace, and the nucleolus and nuclear chromatin in the periphery produces a peri-inclusion halo. Okay, so this is might be a little complicated. So there is something called Lipscomb's bodies. This I don't know how to pronounce it, guys. I'll just call it Lipes bodies. These are your intranuclear inclusions, which are eosinophilic, ovoid, and homogeneous in structure, which tend to displace nucleolus. Okay, producing nuclear chromatin, which shows a peri-inclusion halo. Okay, now it is multinucleated infected epithelial cells formed when fusion occurs between two adjacent cells. Again, the same thing is happening, that there is multinucleated cells. These cells are infected epithelial giant cells, and when they fuse, there is fusion occurrence between the adjacent cells. Intracellular edema is also seen, which leads to the formation of intraepithelial vesicles. Now there is mucosal vesicles which rupture rapidly. Then the surface tissue covers with fibrin, PMNs, and degenerated cells. Now subjacent connective tissue is infiltrated by inflammatory cells. So mainly you need to remember a few things in histopath. First is the ballooning degeneration. Here you have to describe about the infected cells and their nucleus. Then you have to know about acantholysis and Zang cells, and there is the edema of the epithelium and break in the basement membrane. Then you have break in the epithelium, that is your acantholysis. Then you have to talk about these Lipscomb's bodies, and you have to know that they are these peri-inclusion halo. They produce a peri-inclusion halo. And you have to talk about your inflammatory cells as well, and there are a few PMNs, degenerated cells, and fibrin. Coming to the last part, that is your diagnosis. It can be diagnosed by clinical procedures and laboratory procedures, and there is viral isolation and identification. Then so basically these are all your diagnostic tests. One is your clinical tests, lab tests, and your then you can isolate the virus to identify it through culture and various inoculation methods. So there is one thing called immunofluorescent staining, where you prepare a smear and there is an impression and crystal section with fluorescein. okay, fluorescent dye, and labeled as HSV protein, antibody protein. So basically you stain the virus with an immunofluorescent stain. That is about it. And then there is another similar type of technique, that is your immunoperoxidase technique, where it is more sensitive than the immunofluorescent technique. Then coming to the serological tests, you can perform an ELISA or HSV antibody test. Okay. Then Zank cell test is also a test of diagnosis, where you can check the balloon cells, multinucleated cells, and intranuclear inclusions. Then at the end, if nothing works, then biopsy is always good for a pathologist. Then DD is recurrent, and so is basically a differential diagnosis. It could be confused with herpes zoster. Okay, that is very important in all of these. Okay, aphthostomatitis also could be a DD. Okay, then coming to the treatment, it is a viral infection, so antivirals, that is your acyclovir, zidovudine. Usually acyclovir is the most preferred drug. Okay, zidovudine or idoxibudine is also given, but acyclovir is the most preferred. Then coming to the antibiotic therapy, this helps with the prevention of secondary infection. Then NSAIDs to relieve pain, discomfort, and sometimes topical anesthetic gels can also be given to relieve the discomfort. So that's about HSV. It is a huge chapter, a topic, not a chapter. I hope you learned something through this lecture, and if you did, please subscribe to my channel and let me know if you have any doubts regarding HSV. Okay, thank you for watching. Have a nice day.